Thank you so much. Now I'm going to ask everyone to come back on to do the question and answer session of our meeting. Dr. Memi, Dr. Weber, Dr. Ferries, Sullivan, Carvajal, et al. And I'm going to start with Dr. Weber, and feel free to answer and chime in, anyone who's here. But, during this pandemic, what do you say to your patients who are on therapy or who finished therapy and want to know about the appropriateness for the COVID vaccine?
So at our institution, we encourage everyone who's has a history of melanoma or has melanoma and is being treated with immunotherapy to get treated in between their treatments. Since the vast majority are either every 3 or 4 weeks, that means at least a week before or after treatment. I would expect, based on my experience with a neoantigen vaccine that's been tested and given with PD-1 blockade, that the side effects will be somewhat worse than what you would expect with just vaccine alone, but not intolerably so. But I think everyone should get treated. There was a question about the use of steroids, and unfortunately, I think if someone's on prednisone more than 10 a day equivalent and or other immunosuppressants, the likelihood that getting vaccinated is going to help them is really low. And I personally would wait till you can be tapered off steroids before getting a COVID vaccine.
If I could just jump in for a second. So you mentioned IO, but there are many people out there taking a targeted, and I was hoping you could address that as well.
Yeah, I don't see any issue with the targeted therapy. Again, just to play it safe, to make sure that any side effects of the vaccine would not occur and be confused for a targeted therapy side effect. If you get your vaccine, I'd probably skip a couple of days of whatever it is, dabrafenib, trametinib, Encobini, Vamcobi, just to play it safe. Skipping a few days in someone who's been on those drugs for months wouldn't be a real problem for me.
Okay, great. Dr. Sullivan, a question comes. So what biomarkers do I need to get tested as a patient for adjuvant and metastatic decision-making?
So the most important factor or most important biomarker that we check for anybody who has either stage 3 or stage 4 disease is molecular analysis to determine whether there's a BRAF mutation or not. Our general policy is to actually do a much more expanded analysis that covers mutations like NRAS, mutations like NF1, but then also mutations or alterations of the gene in a gene called NTRK and other genes where there may be drugs that are FDA approved to treat those. So there's a drug that's approved for a very small percentage of patients with melanoma will have an NTRK fusion, which can drive the tumor growth. There's drugs approved to block those fusions across cancers. So I think a more expanded genetic analysis to just determine what's possible. And then even though there's no FDA approved drugs for NRAS mutant melanoma or NF1 mutant melanoma, there are clinical trials that we and others are running, trying to understand whether we can more effectively block these targets. And so I think it's useful. It may not help in terms of figuring out what to do first, but it certainly may help to figure out what to do second, or also direct potential clinical trial enrollment. Another thing that's thought of would be Pdl-1 testing. It's not something we do routinely at our institution in melanoma patients. It's routine in lung cancer and many other cancer subtypes. The reason we don't do it is we don't have it's really not in our treatment algorithm. If positive, a certain percent do this, if not, do that. And so we haven't been doing that because if somebody has metastatic melanoma or has high-risk melanoma, they're a candidate for a PD-1 inhibitor, whether they do or do not have a certain percentage of staining in their tumor of Pdl-1. But that's something that might be done on a patient's tumor. Be interested to hear from the other panelists if they had other thoughts on that.
Yeah, so standard at our institute is what you've said, but we also have started to look at, a full sequencing panel only because there are now opportunities within the clinical trial sphere to do that. And that transitions into a discussion. Dr. Carvajal, what would you say to same patient but with an ocular melanoma?
Yeah, so again, molecularly, it's very, very different disease. Uveal very rarely, if ever, will harbor these BRAF mutations or NRAS mutations that are common in cutaneous melanoma. So at our institution, we will do our melanoma panel on our uveal patients, despite the fact that usually I kind of know what we're going to find. With ocular melanoma, the vast majority of cases will be driven by these GNAQ and GNA11 mutations, which we'll find in over 90% of the cases that we test. These tumors will frequently have loss of something called BAP1 or mutations in SF3B1. Those are also part of our panel. We do it more although we do it, they tend to not drive treatment decision making.
Okay.
I guess one thing that I will add, on our panel, we can estimate tumor mutation burden. Typically, the mutation burden in uveal melanoma will be quite low. It's very, very low, particularly compared to uveal melanoma, but a small proportion of cases will have a high mutation burden, which can respond to checkpoint blockade. Something to think about looking for, but again, it's going to apply to a very small proportion of patients.
Wonderful, thank you. Dr. Ferries, we sort of hit on a lot of these local injectables and oncolytics. Can you tell me about your experience and where you would utilize those for patients that you see in the clinic?
So yeah, so the oncolytics are relatively new, but intralesional treatments go way back. And so back to the 70s with the intralesional BCG. BCG is a TB vaccine, but it has been used to inject it into tumors. And the hope with the intralesional is generally not so much to get a benefit in the thing that you're injecting, but potentially to get a benefit beyond that target thing, either with regression of uninjected tumors or potentially as some sort of immunization effect of it. We were part of a trial that looked at TVEC, the currently approved intralesional oncolytic, in the neoadjuvant setting. So injecting tumors for about 12 weeks prior to resection, and compared that to patients who went straight to surgery. And there did just seem to be some benefits that extended beyond benefits of just the local tumor in that trial. It was just a phase 2 trial, so that would need to be potentially confirmed in subsequent studies. But that's one of the goals of injecting those tumors locally, is to not just get a local benefit, but to get a benefit beyond that. It seems to have the most effect in patients who have disease that's limited to either those in transit soft tissue lesions that are close to where the primary tumor was, or potentially lymph nodes. We haven't seen as much benefit in patients that have more advanced metastatic disease, and that's where these combinations may or may not be helpful over time.
Okay, thank you. Dr. Memi, this idea, one of our people here asked, what if I've gotten a Keytruda and I responded and then I stopped therapy and the tumor starts to grow again? Should I change therapy? Should I go to a combination? What should that type of patient do?
I think that's a great question. I think some of the data is coming out and other trials are ongoing, but if somebody's been on Pembro but had stable disease, or even a significant response, and after that perhaps they were off drug for one reason or another, and then had disease recurrence or progression. So those are two different scenarios. On treatment progression, it indicates more of a refractory disease and may need a clinical trial versus combination approach with ipi-nivo. And if it's a situation where patient had a significant response and went off treatment, and there's a potential for re-challenging and attaining that response. Not all of those re-challenged patients will respond. There's only a subset of them, but I think close to 1/3 will, if I remember the data correctly. So I think there are two different subsets, and in either case, I think, like we always and all of the panel members have advocated, a clinical trial setting in that kind of situation is probably more appropriate.
Okay. Dr. Weber, the same in the adjuvant setting. When someone is on a therapy and has tumor recurrence or finished for some time and then has recurrence, can they be retreated with the same drug? What fuels your decision-making for those patients?
Yeah, in the patients that I've treated who relapsed and were re-resected to again render them free of disease after failing adjuvant nivolumab or pembrolizumab, especially if it's during or within 6 months and they're BRAF mutated, they're going on dabrafenib intramed. Even if it's a long disease-free interval and they're mutated, I'd probably put them on dabrafenib intramed. If they are BRAF wild type, meaning they do not have the mutation in their tumor, and they relapse within 6 months, that's a tough proposition. If I could, I would give them ipilimumab, nivolumab. The problem is that's not been shown to be any better than nivolumab alone in a randomized trial. If they develop metastatic disease, obviously I'd give them the combination. But if someone relapsed after adjuvant nivo or pembro more than 6 months to a year after having had the treatment, I would consider retreating them again if they were BRAF wild type.
Okay. Thank you. How about in relation to toxicities? Let's say we have a patient who is BRAF wild type and has a significant toxicity on a checkpoint inhibitor. What's your therapeutic plan on treating them or retreating them with this type of drug? And I'll leave it to the panel to comment on their practice.
I can go first. So toxicity related discontinuation of therapy, if it needs to be, I mean, obviously it needs to happen because we don't want to cause any, sustained damage to any of the organ systems. I think if they're BRAF wild type and they've had some degree of response, there's a choice of continuously monitoring that response before taking any steps to reinstituting therapy. Or at times the practice is, most of the time we use steroids to sort of improve those adverse event profile. And in some cases, in chosen few, you can leave a low dose steroids while you reinstitute the immunotherapies if you have to. But if you're continuing to see a sustained response, those patients could be potentially monitored.
Anyone want to add to that?
Yeah, I can add a little bit. So say a scenario where you really feel like you need to go back on the treatment. I totally agree with Dr. Memi that if patients having a great response, it's certainly I feel comfortable monitoring if they've had a tough toxicity. What I usually will do is involve our disease expert. So for example, if colitis is the toxicity, I'll involve our gastroenterology team. And we'll come up with a plan if we have to resume treatment that hopefully will help prevent the recurrence of that toxicity. So if it was really severe, oftentimes we'll start a therapy that can potentially blunt the toxicity. So there's a drug called infliximab, which we give for colitis. Sometimes we start that if we're going to go back onto a checkpoint inhibitor because the toxicity of colitis was so bad the last time. Sometimes patients will have really bad arthritic symptoms or things like that, and we've started patients on a drug called tocilizumab, which is near and dear to Dr. Weber's heart because he's doing a trial of tocilizumab plus ipilimumab and nivolumab. So I think we really try and be thoughtful about which patients do we absolutely have to go back in and treat with checkpoint inhibitors, and then how can we best mitigate the toxicity. We know if we give steroids with the immune checkpoint inhibitor, we probably won't see that side effect, but we also probably might blunt the effectiveness of the treatment. So we're trying to balance minimizing the side effect without getting in the way of the drug helping the patient with regards to treating the cancer.
Very good. I'm going to leave it with Dr. Sullivan. We didn't spend a lot of time talking about a subtype of melanoma mutations, and that's the NRAS mutations. If you could just begin with your thoughts there, and I'll leave it open to the group to comment.
Sure. So NRAS mutations are seen across all subtypes of melanoma except for sort of choroidal melanoma. So eye melanomas that develop on the white part of the eye, or on the conjunctiva, can actually have NRAS mutations, but the ones that sort of start in the retina don't. But the rate of NRAS mutations can be between 10 and 25%, ranging from like the acral surfaces of the skin to the sun-exposed areas of the skin. So it's not an insignificant percentage of patients. It's been studied with targeted therapies against the protein called MEK. And MEK inhibitors can lead to responses in as many as 20% of patients when you just give it by itself. The problem is when there was a clinical trial comparing MEK inhibitors to a standard of care, and this was a trial from about 7 or 8 years ago, at least when it launched, it showed that patients didn't have significant benefit. I mean, actually statistically significant benefit, but not clinical benefit that was kind of justifiable to lead to FDA approval of the drug called binimetinib, which was one of the MEK inhibitors. There's been studies looking at combinations of MEK inhibitors plus other drugs, and really it's been challenging to give combination therapies with MEK inhibitors. And so we're now looking at other types of inhibitors of that MAP kinase pathway. So we've done studies with ERK inhibitors, which is a little bit lower down on that. So if you think of a pathway as a river, it's kind of just further to where the river kind of goes into the ocean. And that's what we're trying to block. And the benefit seems similar, maybe 15-20% single agent response rate with ERK inhibitors. But these drugs seem to be a little bit better tolerated. And we're hopeful that there'll be combination therapies with ERK inhibitors and other drugs that may lead to better benefit in more patients because it'll be more tolerated when we give those combinations. So that's kind of where we are. We don't have any major breakthroughs right now to present, unfortunately. There's been some frustrations with the MEK inhibitor story, but we're continuing to look at it because it's a sizable subset of populations. And we know that some patients really benefit from targeting this pathway, and we're just trying to optimize that.
Thank you. Dr. Carvajal, last question here, and that is, does toxicity to these immune therapies mean that you're really benefiting? How do you deal with that when your patients ask?
Yeah, so that's a great question for Dr. Weber, I think, who's published some really nice work on this front, where it does seem that the based on his work, that the development of toxicity does predict benefit, and that the use of immunosuppression does not necessarily blunt those benefits. But different data sets are showing different things. For myself, I do like to see a little bit of pruritus, a little bit of skin toxicity. It does tell me that something's happening.
I agree with Rich. I think we would all agree that if there's vitiligo and skin toxicity, that's probably associated with a good outcome in melanoma when you use checkpoint inhibitors. But for the other toxicities, the data is not really very strong. There's probably a minimal association. Now, in lung cancer, head and neck cancer, I think it's pretty clear that there does appear to be some association. It's particularly strong for lung cancer and large series. Interestingly, in melanoma, other than skin, it's pretty weak.
All right, so with that, I want to thank everyone for taking time out of their day, the patients, the Facebook attendees, the people from all over the world, and of course our distinguished speakers. I want to bring the focus back to Samantha Guild and what she has been doing to take AIM higher and further than it's ever been before. And I will give the floor to Samantha to just let us know a little bit about what's coming up, and we'll see you in 1 year.
So thank you so much. First, I want to thank the, the Angeles Clinic for joining, our panelists, all of you who have joined and spent the morning or afternoon, depending upon where you are, to join us. Lots of really great questions. So we have lots of resources. There were questions there we weren't able to get to. We have an Ask an Expert. She's a PA who specializes in melanoma. Please feel free to reach out to her. I put the link into the chat so you can reach out to her afterwards. We have side effect management sheets. We have webinars that are coming up to address psychosocial needs. We have more webinars coming up this spring. The next one is on March 13th with the UPMC. We've got one with Banner Health. We actually have, I think, 6 total this spring alone. Again, lots of resources. Reach out to us and we will do everything we can to assist you. I want to let you know that we did record this event. So if you're watching us on Facebook, we're posting it there. If you registered for the webinar, you will get the link to you, hopefully within the next few days. There's going to be a survey that's being pushed out. Please respond to that survey. Give us feedback. We read every single response. Again, everyone, thank you so much and stay safe. Take care. Bye.